So, Assalamu alaikum wa rahmatullah. Good morning, ladies and gentlemen. It is my honor and pleasure to welcome you to the second day of the third International Patient Safety Conference done by the Saudi Patient Safety Center. My name is Dr. Abdellah Al-Hawsawi, and I'm going to be moderating this first session. So this is the keynote session for the second day, and it's my honor and pleasure to introduce the speakers. What I'm going to do is I'm going to introduce every one of them in details before their lecture. But just so you know, we have three heavyweights for today's keynote. My very good friend and colleague, Dr. Neelam Dhingra Kumar from the WHO, Professor Paul Bowie from the Bay State Health, and also Dr. Michael Ramsey, who is from the chairman emeritus from the Baylor University Medical Center at Dallas. So again, I'm gonna introduce him in details before the lectures. So starting off with Dr. Neelam Dhingra Kumar, who's the coordinator for patient safety and risk management at the World Health Organization, and she leads the flagship initiative of the WHO, A Decade for Patient Safety, and she's going to talk about the WHO action plan for patient safety. So,
Neelam, the floor is yours.
Good morning, colleagues. It's such a pleasure to join you today at the third SPSC Patient Safety Conference. And first of all, I would like to congratulate and thank the organizing committee for an excellent program for the Patient Safety Conference and for inviting WHO to participate in this extremely important conference. I'm going to speak on the WHO Action Plan for Patient Safety. The journey of patient safety over the last couple of years has been unprecedented. The global patient safety movement, which we have seen since 2016, has been unparalleled, and 2019 was the watershed moment for patient safety when the 72nd World Health Assembly adopted a resolution on global action on patient safety. This was a landmark moment when the World Health Assembly recognized patient safety as a global health priority. I have to start again, I'm sorry, because there's some interruption I got here.
It's okay.
So could we start? Yeah, could we start from the beginning, because my slides got stuck here. Yeah, so I just want.
okay, so apologies for the technical difficulties. We're just having some technical difficulties with Dr. Neelam's connection. So hopefully she'll be back with us soon. I think I can see her. So if the
I'm not able to share my screen as of now. Yes. Now can you see my screen? Can you see my screen now?
Now we can see your screen, yes.
Right. Okay. So if I may start.
Please go ahead.
Good morning, colleagues, Dr. Abdullah, and apologies for this automatic sign-off which I experienced just now, but I'm so happy to be connected in real time with colleagues from around the world. And thank you so much, Dr. Abdullah, for your kind introduction. And it is such a pleasure. And thank you so much indeed to the organizing committee for inviting me, inviting WHO, giving an important topic to speak on, which is really the roadmap for WHO and the world for next 10 years on patient safety. So I've been asked to share with you the journey of WHO on patient safety, particularly focusing onto the WHO action plan for patient safety, which is the journey for eliminating avoidable harm in healthcare as a roadmap, as a strategic direction for next 10 years globally on patient safety. There has been unprecedented global patient safety movement since 2016, since the initiation of the Global Ministerial Summits on patient safety. And the landmark, of course, was in 2016. There was the Jeddah Summit under the leadership of Saudi government, and that was really what led to a major development and of the momentum which was created from 2016 through these annual ministerial summits. And in May 2019, the World Health Assembly adopted a landmark resolution on global action on patient safety. This resolution also recognized patient safety as a global health priority and established an annual World Patient Safety Day to be observed on 17 September. In addition, this landmark resolution also asked WHO's Dr. Tedros, Director General, to develop a global patient safety action plan from 2021 to 2030, working with member states and all key partners. The purpose of the action plan is to provide strategic direction to all stakeholders through policy action, develop a framework so that countries could take forward national action on patient safety, and also align with existing strategic instruments which are there already at country level for promoting patient safety in all clinical and health programs. And in addition, provide implementation guidance for the mandate provided by the World Health Assembly Resolution of 2019, which is WHO 72.6 on global action on patient safety. We went through an extensive process during the development of the Global Patient Safety Action Plan, through scoping and literature review, through several rounds of internal consultation in WHO, through the regional offices and country offices and across different departments of WHO. And we had an extremely important engagement with experts from around the world through a global experts consultation in 2020, February, where we had experts from 44 countries, and we had more than 150 participants and experts who gave us recommendations on 12 thematic areas for patient safety, which founded the formation of the action plan. So the drafting and review task force developed the first draft of the action plan, which went through public consultation, as well as through member state consultations in 2020 and early 21. And it led to development of an advanced and mature draft of the action plan, which was submitted to the World Health Assembly for adoption. And it was adopted by all member states of WHO and formally launched by Dr. Tedros, Director General of WHO, in August 21. The decision which was taken by the World Health Assembly in 2021, last year in May, not only adopted the Global Patient Safety Action Plan, but also requested the Director General to report back on the progress in the implementation of the Global Patient Safety Action Plan for a period of 10 years, so every 2 years to report to the World Health Assembly. And the first report is due in next year, and we are currently in the process of a member state survey to collect information in order to report to the World Health Assembly next year. The Global Patient Safety Action Plan is a very comprehensive and systems approach to improving patient safety, with a vision in which a world in which no one is harmed in healthcare and every patient receives safe and respectful care every time, everywhere, with the goal to achieve the maximum possible reduction in avoidable harm due to unsafe healthcare globally. And you can see that it identifies some key stakeholders, government institutions, healthcare facilities and services, stakeholders, including patient organizations, professional bodies, academic and research institutions, and also WHO through its different levels of the organization. The action plan provides some very important guiding principles and also based on a framework of 7 strategic objectives, which you can see here, and I will go into a little bit of detail of these strategic objectives, which is, as I mentioned, is a systematic and systems approach to addressing patient safety. So the very first strategic objective is for policies to eliminate avoidable harm in healthcare, making zero avoidable harm to patients a state of mind and a rule of engagement in the planning and delivery of healthcare everywhere. And this is particularly for policymakers and healthcare leaders around the world to work towards policies for eliminating avoidable harm in healthcare. The strategic objective 2 for building high reliability systems and health organizations that protect patients daily from harm, particularly focusing on human factors in application of ergonomics in the interaction of healthcare workers and patients with the healthcare system. Safety of clinical processes to assure the safety of every clinical process everywhere in every setting around the world, and particularly focusing on several areas and pertinent to the theme of this Congress on diagnostic safety, in addition, medication safety, surgical safety, infection prevention and control, blood transfusion safety, medical device safety, so that we identify the risk-prone procedures and put in place measures so that the risk of harm during clinical interactions could be reduced to a minimum. Patients and family engagement as a very important pillar and strategic objective of the action plan to engage and empower patients and families to help and support the journey to safer healthcare. This one particularly relates to building the capacity of patients' advocates and also having their full engagement in co-development of guidance to countries on patient safety and their full involvement in organizational governance as well as policy formulation, in addition to direct care for themselves. Strategic Objective 5 on health worker educational skills and safety, particularly very relevant during the COVID pandemic, to inspire, educate, skill, and also ensure health workers that they are safe to contribute and to the design and delivery of safe care systems. So there is no patient safety without health worker safety, and it's extremely vital to protect health workers while we are building their skills and providing opportunities for education and also inspiring them to work in health sector, which is something which their role they have an important role in the design and delivery of safe healthcare systems. Strategic Objective 6 on information, research, and risk management, which then leads to improvement. So ensure a constant flow of information and knowledge to drive the mitigation of risk and reduction in levels of avoidable harm and improvements in the safety of care. And finally, synergy, partnership, and solidarity to develop and sustain multi-sectoral and multinational synergy partnerships and solidarity to improve patient safety and quality of care, and bringing together technical programs as well as clinical and health programs and embedding patient safety strategies in every health and clinical program. The framework for action which the Global Patient Safety Action Plan provides is a 7x5 matrix, the 7 strategic objectives, and each one of them implementable through 5 strategies. So that makes a 7x5 matrix. And this is truly an approach to plug the weaknesses in health system to ensure patient safety. The action plan also has an important component of monitoring and reporting, and it provides 10 core indicators and a set of advanced indicators which are aligned with the different strategic objectives. For example, the strategic objective 1, number of countries that have developed a national action plan for implementing patient safety policies and strategies, and asking countries to prioritize and work towards implementing the action plan as well as report to WHO and also have systems to collect information for improvements in the country. WHO, as part of its global call for action and being at the forefront of response and action on patient safety, has launched a Decade of Patient Safety initiative, which is aligned with the Global Patient Safety Action Plan to facilitate and promote World Patient Safety Day, to work with countries to implement Global Patient Safety Action Plan, to also implement and call countries to prioritize medication without harm, which is the third ongoing Global Patient Safety Challenge. Through Global Patient Safety Collaborative, work with developing countries to set up systems for leadership, education and training, as well as research capacity in patient safety, and have a global patient safety action network, which provides a foundation of bringing together stakeholders, again, in our journey to implement the action plan and improve patient safety. Recently, WHO also launched a guidance on implications of the COVID pandemic for patient safety as part of several patient safety standard guidelines and tools which WHO is developing. And finally, major work on patients and family engagement through Patients for Patient Safety initiative and bringing patient voice as part of the developmental process for a safer health system. To conclude, I would just like to focus on 10 actions which WHO is urging every country to take in order to implement the Global Patient Safety Action Plan through development of a National Patient Safety Action Plan, which is aligned to the Global Patient Safety Action Plan, to establish a patient safety incident reporting and learning system, also aligned with WHO guidance on patient safety incident reporting and learning systems, and also several examples of countries which have established successful and effective patient safety incident reporting and learning systems. Implement the WHO Global Patient Safety Challenge on medication without harm through its 4 key domains on patients and the public, healthcare professionals, medicines, and systems and practices of medication. Celebrate and observe World Patient Safety Day every year, aligned to the theme of World Patient Safety Day, and have focused action utilizing this huge platform of for public engagement and as well as enhancement of knowledge of communities and families on patient safety. Operationalize a national patient safety network, bringing together all stakeholders aligned with the global patient safety network. Incorporate patient safety curriculum in medical and nursing professional education to build a capacity at point of care. Report progress on patient safety through the member state survey to the World Health Assembly, and the first survey is currently ongoing. Institute a policy of having a patient representative in all hospital governing boards. And these actions, I must say, particularly aligned with the core indicators on which we are urging countries to report progress. Step 9 is to prioritize and provide resources to patient safety programs. Again, integrating patient safety strategies in different clinical and health programs and safety programs, and provide sufficient resources through prioritization to patient safety. And finally, strategize patient safety as a force multiplier for health services improvement programs, particularly related to infection prevention and control and quality of care. So with that, colleagues, I would like to conclude my presentation and look forward to working with you in the journey for creating a world in which no one is harmed in healthcare and every patient receives safe and respectful care every time, everywhere. Thank you very much indeed, Dr. Abdulillah, for this opportunity, and thank you very much to the Saudi Patient Safety Center for their leadership in organizing this conference.
Thank you very much, Dr. Neelam, for a brilliant presentation. And I really liked the very practical, actionable recommendations that you put in at the end. So we know that you have to run, and we'll do the Q&A. If you don't mind, we'll just take a few questions before we can move on. So the first question that I have for you is, are you collecting the member state survey annually to measure the compliance, or how often are you collecting the data in the WHO?
The requirement to report to the World Health Assembly is every 2 years. So WHO plans to undertake the survey every 2 years. However, considering countries are setting up their systems to collect information nationally and from from all levels of healthcare, it is advisable to countries to set up systems for annual collection so that they could see the improvements every year. However, at the global level, the reporting would be every 2 years.
Okay. And there was a question about, is the action plan customized to fit the income status of the countries, low middle income countries versus high income countries?
Absolutely. The strategies, the way they are outlined, they are actually applicable to all settings, all national level, local level, as well as regional and sub-regional level, as well as to all strata and category of countries, low and middle income countries and high income countries. Countries, of course, need to implement the action plan based on their national priorities and context, but the strategies are truly applicable in all settings and all category and all levels of development of health systems in different countries.
Perfect. And there's another question, which is, it is a 9-year long plan. Is there a room for editing or updating the plan during that period?
So at the global level, the action plan has been adopted by the World Health Assembly. So the action plan is not, we don't plan to modify the action plan over the 10 years. However, at the national level, again, there is flexibility for countries and whichever level the action plan is being implemented to totally adapt to the local situation and national situation.
Perfect. So, this is a question from me. What do you want the audience? Then predominantly they're from Saudi Arabia. What is the one or two things you want them to do over the next year?
So first of all, I must say that the patient safety systems are very well developed in Saudi Arabia. The organization of the summit in 2019 and sharing of best practices and case studies and success stories from different levels of the healthcare system in Saudi Arabia demonstrated a deep implementation across the country of patient safety strategies. So I think one of the main actions which Saudi Arabia and the patient safety program in Saudi could support countries around the world to sharing of best practices and what works and what doesn't work in different setups. So I think as a leadership role in patient safety, it's extremely important to support and work with countries around the world in sharing best practices. That's the first thing. And secondly, of course, looking into how the action plan could be aligned, or the national action could be aligned to the action plan, so that when we are demonstrating improvements globally, the improvements can be successfully collated and presented at the global level. So aligning national action with the global patient safety action plan strategies is another important call for action. I would urge the government and the institutions, Saudi Patient Safety Center in particular, to consider. But I must mention here that it's exemplary how the WHO Collaborating Center on Patient Safety Policies and Strategies at the Saudi Patient Safety Center has taken the leadership in organizing a series of educational programs for countries around the world, which is exemplary, and it's really benefiting participants and experts and those who are working in different settings to understand patient safety concepts as well as apply those to their local context, local settings. So a hugely important role which Saudi Patient Safety Center is playing, and I congratulate the leadership for the initiatives. Thank you.
Well, thank you very much, Dr. Neelam. Thank you for your leadership globally. Thank you for your friendship. Thank you for your optimism and kind of pushing the agenda forward. So we know that you're very busy and you need to get to your busy schedule. So again, it's a pleasure to have the opportunity to talk to you, and hopefully we'll meet in person soon.
Such a pleasure. Thank you very much indeed for this opportunity.
Take care.
Thank you.
So we are living in COVID times, and the next speaker was supposed to be with us in person, Professor Paul Bowie, who is a professor at the NHS, and he's a human factors engineering expert. Unfortunately, we basically learned that he was not going to be able to attend. Am I still correct, or is he going to be able to be with us? He's not. So basically, we got the news that he got COVID, but we have a recording of his very important lecture that he made for us. So we're going to play that, and unfortunately, we would not have an opportunity for Q&A, but we will, please, if you guys have any questions, share them with us, and we can email those questions to him. And hopefully, once he feels better, we can get back to you with answers. So we'll go ahead and run his lecture. Thank you.
Good morning, everybody, and thank you very much indeed to my colleagues in Saudi for the opportunity to come along here today to present on human factors for diagnostic safety. So my name is Paul Bowie, and I'm Programme Director for Safety and Improvement with NHS Education for Scotland, based in Glasgow in the UK. I'm a chartered human factors specialist, and I've worked in healthcare for around 30 years or so in a range of quality and safety leadership roles, and also for the last 20 years in doing research in these areas. So the purpose of this session today is to outline in general terms what human factors is as a science and a profession, and also importantly what it's not, because unfortunately there's much confusion in healthcare, as we shall see. And so the focus of the conference is on diagnostic safety, and so what I'll do is give examples of the human factors perspective on diagnostic safety, and give you some concepts and maybe some practical methods about how we can consider diagnostic performance, particularly from a safety perspective. And then in a live session, we'll have an opportunity to have some Q&A. So it's always good at the start to define what we mean by human factors. And we can see here the official definition from the International Ergonomics Association. And it's worthwhile breaking that definition down. I mean, I know it's a bit academic, but it's worthwhile breaking it down. So perhaps the first learning point is that human factors is also known worldwide as ergonomics. And that's a term you may have heard of, but you may not have been aware that from a science and a professional point of view, we see both terms as being synonymous with each other, and so we tend to use them interchangeably. And so in this definition, we can see that human factors or ergonomics is concerned with the understanding of interactions among humans and other elements of a system. Now, the second learning issue here is that if you notice that humans are not different from the system. So we often see in healthcare that people tend to focus on blaming the system as a problem. It's a system issue. It's got nothing to do with me. But from the human factors perspective, humans are central to all care systems. The care systems revolve around them, and humans interact with every element of the system, as we shall see. And what is the purpose of human factors? And that's outlined and described in the last part of this definition. This is what's known as the twin aims. So the purpose of human factors is to jointly optimize both human well-being and overall care system performance. So that's a really academic definition. Perhaps a much easier way that you can see on the screen there of defining human factors is the study of designing for people to make things easier, safer, and usable. Alternatively, you can see it as the study of system factors that make everyday work harder or easier. And so there will be many people attending the conference who are actively involved in improving human work in healthcare. And you may find yourself being part of one of these professions or disciplines. So we have many people who work on patient safety and clinical risk and quality improvement. We have obviously people at the sharp end of practice, so clinicians and leaders and managers and scientists. And we have human resources professionals. We have researchers. What we don't have a great deal of are human factors specialists. And that's a problem just in the UK, as well as in Saudi Arabia, but also in other modern healthcare systems worldwide. So all these different professional disciplines have an active role in improving everyday human work. But what distinguishes human factors from these other disciplines? Well, there are three distinguishing factors. So human factors always takes a systems approach, a holistic overview of the nature of problems or issues or irritations and frustrations. And the framework that you can see in the right-hand side of the screen is an example of a systems-based framework, and we'll come to that later on. The other issue and distinguishing feature from a human factors perspective is it's always design-driven. So as a human factors professional, we know a great deal about human characteristics, their capabilities and their needs, and these have to be accounted for in the design of technology, in the design of care processes, and the design of overall care systems, and also in the nature of the complexity of the job tasks that we undertake as well. So there's a design focus there. And as I've already mentioned, it focuses always on these two outcomes: system performance and human well-being. And these are issues I think that the other professions and disciplines don't necessarily focus on. They may focus on an aspect of well-being, or they may focus on an aspect of performance, but rarely do they see them together. So from the human factors perspective, all of these issues are inextricably linked. The other issue is that the other professional disciplines don't tend to take a systems approach in the way that human factors envisage what a systems approach should mean in complex healthcare systems. And that's something else we can debate. It's worthwhile pointing out that that human factors, as is both a science and a profession, is significantly well established in all other safety critical industries, and I've described some of them there. So in the nuclear world, in transport, in the petrochemical industries, human factors specialists work as embedded professionals alongside military personnel, alongside engineers and technicians and leaders within these industries. So it's seen as being normal. Unfortunately, in healthcare, we are nowhere near that situation, which is a bit disconcerting because healthcare is so safety critical. So that's one aspect. The second aspect is that you can make an argument that healthcare is the most complex work system that has ever existed. Yet these other industries take safety performance so seriously that they employ dedicated professionals to support them in that regard. In healthcare, we're a long way from employing dedicated safety scientists such as human factors professionals. And to make a very quick comparison, in Europe, there's an air traffic control body called Eurocontrol who control the skies over Europe, as you can imagine. Now, they're an organisation with around 7,500 employees, and they employ 40 human factors professionals embedded alongside these other employees. So to give a comparison with the UK Health Service, and I'm pretty sure you can do the same with healthcare in Saudi, we have over 1 million employees, but we have less than 10 known professionals qualified in human factors working in embedded clinical practice. So there's a significant need, therefore, to build capacity and capability amongst the workforce. And I'm really pleased to say that Saudi Arabia has a strong interest in that area, and based on the good discussions we've had so far with the Patient Safety Centre, and that mirrors what's happening across the UK as well. So we're taking the first and trying to close the gap in education. It's unfortunate, but I have to raise this particular issue. Unlike those other safety critical industries where human factors as a science and profession is well understood and well used. It's unfortunate that in healthcare, there are a number of myths and misunderstandings that perpetrate around what human factors is. And in a recent paper, some of these myths and misunderstandings were outlined in terms of separating fact from fiction. So as you can see there, fact number one, human factors is about designing systems that are resilient to unanticipated events. It's not about eliminating human error, as many people think. You cannot, in most circumstances, eliminate human error. We need to design care systems so that when human error does occur, the system is resilient and can dampen the impacts of these types of errors, and therefore reduce as much as possible the chances of people being harmed. So human factors addresses problems by modifying the design of the system to better aid people. So in some regards, human factors is not about humans per se. It's about designing for humans. So many in healthcare think that human factors is a behavioural science, i.e. it's trying to teach people to modify their behaviours. That's not the way we go about it. We design the system and the technology that people interact with to try and elicit the behaviours that we're looking for. So it doesn't just focus on individuals, it focuses on every level of the organisation. So from culture, from leadership working, from technology, from the built environment, from the tasks that you do, anything that you see as being problematic in your everyday work that causes frustration, that causes irritation, that is safety critical, or could be safety critical, could be hazardous, all of these issues from a human factors perspective are seen as human factors problems because they involve people interacting with these different system elements. So there's no focus just on individuals. We can train people over a few days in foundational aspects of human factors, such as the systems approach and some elements of design thinking. But to be properly qualified in the science, it requires years of training and membership of appropriate professional bodies and ongoing CPD and regulation in the exact same way as clinicians are trained and regulated as well. So these are some myths and misunderstandings that are worth addressing. And so the other issue which is related to that is that human factors is often conflated with all these other important disciplines and professions and initiatives that are ongoing in healthcare. So human factors is not about factors of the human, as about people per se, as we've seen. Human factors is not the cause of failure. Any cause of failure is the fact that you've not considered human factors in the design of the care system. Okay, so it's the opposite of what many people think. And quite with non-technical skills training and quality improvement and simulation, important safety critical initiatives that can take a human factors approach, but we're just beginning to bridge that gap. So it's important that those in simulation who deliver clinical skills should be aware that that's not human factors training, but it could be if we designed that type of training and these types of educational interventions from the human factors perspective. And that's work that's certainly ongoing in the UK and elsewhere. And I'm sure we can share that with colleagues in Saudi. So the focus of the conference is on diagnostic safety. And I'm going to, this could be, from a human factors perspective, it could be a week-long conference just focusing on this. And so you need to forgive me that I can only go into this in a very high level way just now, but hopefully we can get across some of the issues and some of the concepts and some of the practical approaches that may be potentially helpful in better understanding and improving diagnostic performance from the safety perspective. And so the first point to make is that diagnosis is a collaborative effort, okay? So there's an argument to make diagnosis in terms of our cognitive biases, the heuristics that we use. Is it all in your head? Is it all in, or is it all in the system? So academically, this is your diagnostic performance influenced just by your knowledge and training and your expertise? So the in your head stuff, or is there other more systemic issues at play? So this is I think this is a straw man argument, because go back to the first point we made, people are part of the system. So you can't separate people from the care system. And so from the human factors perspective, we should always look on this as a systemic issue. So as we shall see later, people's decision making is hugely influenced, not just by their knowledge and their training and their experience, but by their interactions along with the other system elements. And it's the complexity of those interactions across the system that can give rise to good diagnostic performance, okay, but can also influence and degrade performance so that diagnosis or are incomplete in some respect. And so looking at other system elements, such as information technology, and perhaps the most studied aspect here, is that the design and usability of the information technology systems that we use do not always support diagnostic performance. And they don't support, in general terms, a lot of the times, our own clinical performance, over and above the diagnostic element of it. So the design, the usability, and the safety of our digital IT systems is a significant human factors issue. And so much so that these systems in England over a decade ago, it failed. It was a massive failure, and it was a costly failure, estimated to be anywhere between £10 billion. And most of this was because of the failure to consider human-centered design principles in the development and the implementation of this technology. So a lot of the technology we see is very technology-centered rather than people. Yeah. We also don't know a great deal about the evidence pins how and why things go wrong from a diagnostic perspective. There are techniques which we'll introduce you to in a second or two that can give us a more meaningful understanding of how and why things go wrong from a diagnostic perspective amongst a care team. But overall, I think we need more empirical research in this area. There is an evidence base, but to better understand the nature of what's going on, there needs to be more significant investment in research. And of course, we all work in a work system, and we all work within a safety culture. And exploring the work system and exploring the culture are also extremely influential factors on diagnostic performance, as well as performance in other clinical areas as well. And so finally, we need to recognise that in terms of learning as a science, in healthcare, in terms of the way we're educated and trained, and in terms of our ongoing CPD, not enough attention is given in training programs and curricula to clinical reasoning and the importance of team working and effective and safe communication. So all of these issues together are what we would call user-centered design aspects that would need to be addressed in a meaningful way to better support diagnostic performance. And so let's look at some of the practical things that can potentially be helpful in that regard. So let's look at work procedures. So work procedures is a generic term that can go for organizational policies, clinical guidelines, standard operating procedures, clinical pathways, checklists, leaflets, infographics, and so on and so forth. Nobody in healthcare is trained in how to design perspective these types of work procedures. And these types of work procedures are cited in the vast majority of patient safety incidents as being contributory factors when something goes wrong. But we now have user-centered design guidance around what we should be doing, what are the key steps that we should be taking to actively designing usable, useful work procedures. And so the diagnostic community can be best served looking to embrace this type of approach in order to support their own performance when performing diagnostic tasks. That could be unpacked a bit more from an education and training perspective. There are a small number of systems thinking principles that are extremely important from a diagnostic safety perspective. And these systems are not well understood in healthcare. And so I'm going to unpack one or two of them just now. But again, these principles can be embedded both in education and training, but also in everyday practice, in terms of how we design those work tasks, in terms of how we design procedures, but also importantly, is when we try and learn from when things go wrong. So we need to recognise that when things from a diagnostic perspective, it's caused by multiple interacting contributory factors from across the care system. Largely, it's caused by these interactions. And it's not solely down to the decisions or the indecisions of people at the sharp end of practice. So this is a foundational systems thing. We always try and seek multiple perspectives when attempting to understand any element of system safety. And I don't think we do this enough in healthcare. We may speak to the local multidisciplinary team, the people that we work alongside, but there are others always consider who might be extremely important. You know, so from a diagnostic point of view, we've got radiologists, we've got pathologists, we've got the non-clinicians who may interact in this area. So we may have porters, we may have ward clerks, we may have domestic staff, we may have other staff who touch the diagnostic safety system in some way and may have a better understanding of certain aspects of it that we don't see. So capturing multiple perspectives can be important from understanding where things can go wrong, but also in capturing ideas for how we can improve things. So this is the notion of seeking multiple perspectives. And I mentioned earlier about the confusion often around this term human error. So if you arrive at the conclusion that a human error in inverted commas was made, then this is a symptom of a system problem. It's not a cause of anything. Okay? It's a sign that the system was suboptimal in terms of its design. And so this is not the end point of learning, but it's the beginning of the learning process. We need to uncover now how and why this human error occurred. And that's extremely important from a diagnostic safety perspective. And that means taking the systems approach to more meaningfully better what's going on. And here are two strange and probably new academic concepts. So the concepts of local rationality and the counterfactual reasoning. If a doctor or a nurse making a diagnosis 3 weeks ago, and in hindsight, we can now see that a diagnosis was missed or a wrong diagnosis was arrived at, then we could say that Dr. A or Nurse B should have done something or could have done something else. Okay. This is not learning. This did not happen. What you've just described, if you do that, is an alternative universe, a universe that did not happen. What we need to do is explore the local rationale of the people involved. So they were faced with a patient, perhaps with a complex multimorbidity, polypharmacy, and a hugely demanding, dynamic, interacting care system at that moment in time. It may have been in the middle of the night, resources limited, and so on and so forth. We need to understand the state at that time that the people involved were in, because the decisions that they made at the time made sense to them. Otherwise, they wouldn't have made them. And exploring that and learning from it is where the learning is. The learning's not in saying, well, they could have done this or they should have done this, or I would have done that. That, unfortunately, is not learning. Properly about the nature of what went on, we need to explore the concept of local rationality. This is really important from an investigation point of view, as is this concept. So this concept here about exploring and reconciling work as imagined and work as done is important for patient safety in general, okay, and for quality improvement in general, and also from the diagnostic performance perspective. So work as imagined is what is enshrined in our guidelines and our protocols and our policies. It's what is enshrined in the minds of leaders and managers who don't do sharp-end clinical work. Work is done, on the other hand, is what happens in reality. So there is always a mismatch between work as imagined in the guideline and how the guideline is applied in practice, because the guideline sets out, or the policy sets out, an idealized world that, and so it's never been designed for the fact that you might be too staffed down, you might be more busy than ever, and so therefore you cannot practice to that standard as such, but you can still be as safe as possible, you can still be as efficient as possible in order to get the job done. That's the reality. And so the reality here is that our protocols, guidelines should be designed to reflect the reality of how work is done rather than how work is imagined. And you can obviously see the context where that becomes important from the diagnostic perspective. And so I spoke about the systems approach. This is the Systems Engineering Initiative for Patient Safety, or the SEEPS framework. And this is the most popular human factors method in healthcare, certainly in the UK and the States and elsewhere. It's, as you'll see, it's got a multifunctionality about it. And so what we see here in the SEEPS framework, on the left-hand side, we can see a work system of people and tasks and technology, an internal environment, an organization which they work within, and also an external environment, okay? And so these interactions, if you take part in a care process in the middle, so if you're taking a blood, if you're trying to diagnose somebody with any particular type of condition, then that forces interactions between these work system elements on the left-hand side, which give rise to outcomes. And these outcomes are what you're trying to achieve. So you're trying to achieve safer care. You're trying to achieve good workforce well-being for the staff. You're trying to achieve a good experience. So these are outcomes that we want, okay? But sometimes these interactions lead to outcomes that we don't want, okay? So for example, patient safety incidents or diagnostic error. So that's the way the human factors world understands the nature of healthcare as a social technical system, and how the work that you do leads to outcomes that we're trying to achieve or ones that we're trying to avoid. And so SEEPS is, we're calling it the Swiss Army knife of human factors because of that multifunctionality. And there's just some examples of the different ways that you can use that framework to better understand your clinical work and to better understand. So we use it, for example, in Scotland and the UK as part of safety investigations now, morbidity meetings, and to help us problem solve everyday hassles and irritations. And here's a worksheet that I can share with you. So a simple worksheet that you can write on top of with your team colleagues to try and better understand a particular aspect of your work and achieve those outcomes that you're looking for, or overall tell a system story. There's so many different ways it can be used. And on the reverse of it, we have this idea of performance influencing factors, which is really important from the diagnostic perspective. These are all the different types of issues, and so that can potentially degrade or improve your performance. And these, to some extent, need to be explored, okay, when we're trying to analyse and problem solve in healthcare. So these serve as a prompt or some guides for you to explore as part of taking that systems approach. I mentioned earlier about the cultural context of work. I know that in Saudi there's a strong interest in measuring safety culture. We're using questionnaires amongst the workforce, which is important and it's good to do. But we also have a qualitative approach whereby you can, as a team, meet to discuss safety culture and the certain elements that teamwork and communication and risk that play into that. So you can take a qualitative approach to that. And I'm more than happy to explore with colleagues and share these kinds, which you may want to adapt and translate in some way later on. And so very quickly, and to rhyme off, this document here, it's a full book that's free online about improving diagnosis in healthcare. The reason I raise awareness of it is it takes a human factors approach to understanding the problems in this area. And so, as I say, as a book, it covers in depth all the issues that I've raised today about technology, about teamwork, about communication, about human factors systems approach, and so on and so forth. So on that note, I'll thank you very much indeed.
Thank you very much, Professor Bowie, and we wish you a speedy recovery. I have to say, as a moderator, I'm actually, I want to congratulate the Saudi Patient Safety Center for picking the topics and the speakers. You know, so far, it is exciting to listen to the speakers. So let me just summarize some of what we heard in this brilliant talk, and as you can see that we will show the email that you guys could send questions to Professor Bowie. So he said, people are part of the system. Healthcare is the most complex system created by man. Human factors is about designing the system for individuals. It's not about the individuals per se only. Diagnosis is a collaborative effort. He talked a lot about system thinking, and I think if we counted how many times he said systems, maybe 20, 30 times, and I think that to really send a message that it's not about the individuals, that we as human beings are part of, cogs of this big wheel called the healthcare system. Human error is a symptom of a system problem, not its cause. And then finally, he talked about the system engineering initiative for patient safety. And I would love if the Saudi Patient Safety Center could start such an initiative. I think human factors engineering, the system engineering initiative would be very, very beneficial for the Saudi healthcare system. So on that note, we will move to the third speaker, Dr. Michael Ramsey, who's very, very dedicated to patient safety, that he's staying way up late. I don't know, Michael, if you're in Texas or in California, but wherever you are, it's I think past your sleeping time. So thank you very much for actually making the time. I'm gonna quickly just talk about Michael Ramsey. He's a chairman emeritus of the Department of Anesthesiology and Pain Management at Baylor University Medical Center and past president of the Baylor Scott and White Research Institute. And if you worked with sedation anywhere in the world, you've heard of him, because there's the Ramsey sedation score. So here's the Ramsey in flesh who put it forward, and currently he's the CEO of the Patient Safety Movement Foundation. So Dr. Ramsey, the floor is yours.
Dr. Abdellah, thank you so much. It's a great honor to be part of this talk today and or this meeting, and what an important topic. And I'm so pleased that you're having this session here these 2 days. And hopefully I've had a little trouble getting on this evening or early morning, and I'm going to try and share my screen and see if I can show my slides here. Let's see. The audio system. Okay, I'm not sure where that would be, but can you see the slides? Not yet. Then that's not good. How about now? No? Oh dear. Let me try and get back to the home screen. It says I'm sharing my screen. Can you see this screen? No. I think I'm having a little trouble here. Can you see my screen now? Yeah. Yeah. Oh, okay. Okay. It's hard to click it when you got the slides up. Yeah, I think I'm going to have to, because I'm not getting it here.
Well, what I can tell you, Dr. Ramsey, that we have more than 2,000 attendees, and we'll be patient to hear your talk. So, you know, if I can ask my colleagues from the control, if you guys could run it for Dr. Ramsey.
That would be great. Okay. One last shot. Still can't see my screen, correct?
No, we can't. We can't. But that's part of the resilience in the healthcare system. We have to be resilient to make sure that this works out. Because
Try one more last time. Maybe I've got it now. Let me just see.
Okay.
I think I might have it.
There you go. I think we can see your screen. Yes.
Getting better?
Third time is a charm.
Hey, awesome. Okay. Thank you. Persevering. So I was asked to talk about measuring diagnostic safety. And I think as we sort of guess how many patients get hurt because of safety issues around the globe, it's a total guess. In the United States, we think in terms of maybe 250,000 preventable deaths a year, but we do not know. And we don't know because there's not good data out there. There's not transparency of data. People don't jump up to report. And I think you've just heard in that last talk, finally, we're beginning to get some data because of all the ill-gotten problems of electronic records. We are now beginning to capture data, and payers are starting to capture data, whether the payer is the government or a private payer. But we're beginning now to get to, because of electronic records, we're beginning to get some data to help understand the size of the problem. And it is a big problem. The Inspector General of the United States came out with the fact that there was a plane crash today, a major plane crash. And he was saying, well, there wasn't really, but it's the number of patients that died because of medical error that occurs every day. If we said it in those terms, it would really get people's attention. And so we've got to measure. And so measuring is part of the cure once we really get our hands around the problem. So first, financial disclosures to make. I'm CEO of the Patient Safety Movement Foundation, a not-for-profit, unpaid CEO. And it's been really a phenomenal year for me to have been with this organization, actually hands-on for this year, since I retired from being head of anesthesia at Baylor. And so who are we? What do we do? What is the Patient Safety Movement? Well, it was formed in 2013. It's now almost 2023. And we had the goal of 0 patient harm, 0 patient death by 2020. Well, we didn't get there. So now it's 0 by 2030. And we get asked, you know, how isn't 0 just impossible? But if you think about 2,500 years ago, the Greek physician Hippocrates came up with the term first do no harm, which graduating medical students, still many of them take that oath when they graduate. First, it doesn't say you can do a little harm. It doesn't say some harm's okay. It says do no harm. And that's where we have to get to. but we have to measure it first. We have to know the data to be able to know what we're trying to tackle and what we're trying to reduce to make our healthcare systems so much safer. As a foundation is to make a safer healthcare system with zero preventable patient harm. It's not some, patients, human beings, and some of them are incredibly sick. They are going to experience harm because of their disease, not because of the medical attention they've received. But there are so many patients that are harmed because of failure to institute best practices, evidence-based best practices. So part of our mission is to disseminate actionable evidence-based practices, publish them, get hospitals to commit to them, healthcare systems to commit to them, and establish the culture of safety in their system, and commit to a culture of transparency where they report the data. Because we're human beings, and all human beings are a little bit competitive. And once you see that your data is not as good as somebody else's, you start to move to get better. Data does motivate us. And so these are the organizational aims of the Patient Safety Movement Foundation: transparency of data, evidence-based, have a national patient safety board like a national. A serious error, we all learn from it. We have an independent comes up with a solution and we follow the solution. And unless we publicize these things, and this would, we not all of us learn from it. Many of us don't even know it's happened. And that's not the way to learn. And we want aligned incentives. Let's get paid for performance. Let's get paid for good outcomes. And so one, we want to create awareness of the problem. And we did a survey 2 years ago in the United States. 87% of people felt that hospitals were very safe and were not aware that patient harm did occur, preventable patient harm occurred. And so we want all our healthcare systems to commit to safety. And I'll show you some examples of that towards the end of this talk. We just want to strengthen our network of healthcare systems, because imagine a world where safe care is delivered every time someone seeks medical care. Wouldn't that be wonderful? If you can't hear this movie, please tell me.
It only takes a second to say Gabby Galbo's name, and only a moment to tell you how needlessly she died. But if we were to call out all 250,000 people who die each year from preventable errors in healthcare, it would take us more than 2 weeks just to say their names, and months to list all the loved ones and caregivers who feel the loss every hour of every day. Join us. It only takes.
So were you able to hear that or not? If not, I won't play any more videos.
We did at the beginning, yes.
Okay, right. So the statistics on medical errors is still not clearly known. And so that's the first thing we've got to do. And I see in the Republic of Ireland that they now have a bill before their house that preventable harm must be reported from hospitals. And I hope that passes, and I hope they get really strong data, because data will make us change. But it's thought to be the third leading cause of death in the United States before COVID. COVID certainly stressed our systems and became one of the leading causes of death in the United States. Now, fortunately, it's much better controlled, and people are not dying at the same prolific rate they were 2 years ago. But who knows how long this protection from vaccines, et cetera, will last. So I think we've all got to be very cautious going forwards about preventable infections and preventing spread of infections. And we all got to commit to zero preventable harm, as that's the only acceptable outcome. And there've been many publications since 1998, when Lucien Leap published that there were 98,000 deaths in the United States as a result of preventable error. That error number has just been increasing with each publication, and we guess it's somewhere in the region of 250,000 now. third to heart disease and cancer before COVID came and jumped in front of all of that. So these are our goals. Transparency, I think that's the big one. We've got to have report of preventable harm. And for our payer systems, Medicare in the United States is the biggest payer, and they are reporting on 8 particular episodes of preventable harm, from urinary tract infections, pressure ulcers, etc. And they do report those from the Medicare patients, but we want it from all patients. And we think now we finally got a source where we're going to be able to get this data from. We want aligned incentives. We want to be paid for good quality care, not poor care. We want evidence-based best practices. They should be living documents so that everybody knows what is the best way of preventing a central line infection, for instance. And we need some regulatory oversight from an independent body, and that'd be something like a National Patient Safety Board. Mistakes do occur. We're humans, but we must try to do better, and we aim for a goal of 0. And we need everybody to work with us. We need the patients to work with us. Bring an advocate with them so that when a patient forgets to tell you all the symptoms, you could be a loved one, could be a friend, can go through a list before you come into the hospital, before you visit your physician, and talk about the things that are important. Add in the items that the patient, because they're stressed, forgets to mention. So the patient advocate and the patient with lists can be very important into preventing errors. Question the drug the nurse is giving you. What is it? What is it for? What does it do? And so I think to have an advocate, a wingman, as they had in the movie Top Gun, is very, very important in safety in our healthcare systems. Is 0 possible? I think if we develop a culture of safety, we let everyone speak up if they see something, create a good catch program, celebrate near misses, make this a fun thing, to get people to speak up. And when you speak up, people notice and the information spreads. The single greatest impediment to error prevention in the medical industry is that we punish people for making mistakes. And certainly there's a second victim, and which we've all talked about in the past, where the person gets punished for an error that frequently is a systems error. It's not an intentional error. It's not poor practice. We do have to add to this, you've got to be accountable. So if you're not following the evidence-based best practice, you're cutting a corner, then yes, there does have to be some kind of comeback on that provider. But if this is a systems problem, as most times it is, lookalike medications, dispensing machines that don't work properly, rushed, too many tasks going on at the same time, then we need not to punish people, we need to fix the system. We need the just culture, which is the balance between safety and accountability. And we've got to keep accountability there because we are responsible for our patients. And when we look at adverse events in the hospitals, the Inspector General in the United States looked at Medicare patients that experienced harm in October 2018, and a quarter of Medicare patients experienced harm, a quarter. And that of that quarter, 43%, when they reviewed the electronic records, were felt by physicians and nurses were preventable. And 64% of the adverse events resulted in patient death were preventable. And that showed that we really had not advanced since 2010, because the figures on that review, which was the last review to this one, were very similar. Around 90,000 preventable deaths in Medicare patients due to preventable adverse events. So we've got to do better. We can do better. And I think now, finally, because of programs like this, we are going to do better. So the solutions from the Medicare and the Agency for Healthcare Research and Quality was to update the list of hospital-acquired conditions. In other words, report more numbers than 8 conditions. Look at 20 conditions. Expand safety metrics. Update quality strategic plans. develop evidence-based best practices and provide them for all hospitals and pay on best practices. If you have an adverse event and you're doing the best you could do, that's fine. But if you're cutting corners, that's not fine. So I think finally we're getting a wave of different organizations coming behind patient safety. Research Institute, and number 5 on theirs was cognitive biases and diagnostic error. And diagnostic error is, as I said right at the start, one that is very hard to get your arms around, because if somebody makes a mistake on diagnosis, they're not going to tell you about it unless it's something very serious, in which case it's going to come forwards anyway. So when we look at their causes for diagnostic errors, they came up with 5. There were anchoring bias. The clinician adheres to their initial impression in the face of conflicting evidence. In other words, you diagnose the patient on your first look and you don't look at all the evidence. You're biased because you felt, oh, this is a clear case of something, and it wasn't. Confirmation bias. You just cherry pick the information you're given to support the diagnosis instead of looking at all the information you've got. Actions are driven by emotions, not facts. Outcome bias. Clinical results follow prior decisions, preventing feedback to improve decisions. And so delayed diagnosis due to bias towards COVID, because you feel this respiratory tract infection this patient's coming in with must be COVID. Well, we've got good tests for that, so we'll know within a few minutes whether that's true or not. Diagnostic error can be missed diagnosis, just missed it, delayed, late in setting treatment, or incorrect. And they're the kind of key failures that we have. They're reckoned in the United States, and again, this is all guesswork, 249,000 harmful diagnostic errors annually. 0.7% of hospital adult patients had a diagnostic error. And when we look at the diagnoses that were wrong, colorectal cancer, I mean, any cancer that's missed is terrible. Pulmonary embolus, aortic aneurysm, sepsis, appendicitis. I mean, see all these diagnoses, major illnesses that were misdiagnosed in 2020 in this review that was written by Gunderson. And so around 1 in 20 patients are exposed to preventable harm in medical care. And we've got to focus on preventable patient harm and making sure that starting with diagnosis, that we're on the right track. So what actions can we take to prevent diagnostic errors? Recognize the biases we've just mentioned. Institute timeouts, diagnostic timeouts. Let's review this patient every day. Are we on the right track? Is this the right diagnosis? Particularly for medicine patients. Let's have simulation training in diagnosis. There's no reason we can't. Certainly, I'm an anesthesiologist, retired now, but we did a lot of acute changes on the patient in the sim lab, that because we have to react very fast in anesthesia to correct a problem, attention pneumothorax, edema, all these things that can hurt a patient in minutes. But the same thing could be applied to diagnosis. Critical thinking methodologies, limit patient descriptors, because we very frequently will call someone a frequent flyer. They come in with the same problem again. They're a drug seeker. They're always complaining. Well, this time they may be right. So you can't let these descriptors stop your interrogation of what's going on with that patient. And we need good leadership with all patient safety. It comes from the top down. It comes from your board of trustees down through your total leadership to the lowest paid employee in the hospital. Every one of you have to have a culture of safety. And I'll show you what we did at our hospital, and it was really quite impressive. We need a non-punitive environment, but accountability. We need standardization wherever possible, but particularly with medications to prevent medication errors. And we need to hardwire safety where we can. So we need to be basically a high reliability organization like aircraft carriers, like nuclear power. But the difference there is They're dealing with man and machine. We're dealing with human being and human being. That's two very wide variables that makes it very difficult to be a high reliability organization. But we can at least focus on safety and put safety number one so that we got everybody looking at safety to prevent those hospital-acquired infections. That's something that everybody can be involved with. So we need to pay attention to the frontline workers, what they're saying, what they feel is the problem, where they're having trouble. We need resilience. We just heard that mentioned. We've got to have resilience to be able to detect errors, react, and recover. And this is what we did at Baylor when we had a total new C-suite arrive. They pushed safety number one, and they put these zero harm posters all around the hospital and in patient rooms. And everybody had to write their commitment to safety each year. And everybody working at the hospital had to make a commitment to safety and articulate in one or two sentences what that commitment was going to be. And then at the end of the year, talk about how that's made a difference. Has it made a difference? And what's your commitment going to be the following year? And these are all published on the website and reviewed. And it really made a big difference. And also, we had patient safety officers placed everywhere in surgery, in medicine, so that I know the last time that a foreign object was left behind in a surgical wound. It was over 2 years ago in 51 hospitals. I know what the wound infection rate is for colectomies, postoperative colectomies, for postoperative gin surgery. And why do I know that? Not only do I know it because the data is now being shown and there's transparency, but I know who the surgeon was, who the anesthesiologist was. I know what the body temperature was, what the antibiotic was given, was it the right antibiotic, when it was given, when it was redosed, what was the body temperature, what was the blood glucose, all those things, and it's published, and everybody involved knows those numbers. And boy, does that make a difference. When my anesthesiologist knows that his patient got a wound infection, he's going through every one of those details, and we're going through it too. And we're showing him where the body temperature wasn't correct, the blood glucose wasn't correct, and suddenly the wound infection rates go down. So transparency is incredibly important. And diagnostic errors are really common, they're harmful, they're costly, and so we have to be able to be transparent with them, be open with them, and admit when we've made a diagnostic error. And fortunately, I think with the electronic records, which originally were just billing records, now we're beginning to be able to scan them and get some useful information out of them that can really report on diagnostic errors. Making diagnostic safety is number one. And this comes again from AHRQ, the Agency for Healthcare Research and Quality. But they've really focused this year on diagnostic safety and got to learn what systems and processes to improve and create case examples. And they published many of them, and they're online so people can learn from what they've discovered. And whether you're just starting or you're ready to scale up, what your organization can do now. And so this is a good resource for a healthcare system to just log on to. It's all free, and look to see how you can scale up your diagnostic safety initiatives using multiple data streams. And finally, we need leadership right from the very top. And this is President Biden. He has a President's Commission on Science and Technology, and he also put together a patient safety subcommittee. And that patient safety subcommittee has just come back and reported, and they're coming up with many of the things we've just articulated at the start of this talk. Now, it's very hard for a president to institute these, but as a payer of government patients, the Medicare patients, they can certainly make a big difference, and they're going to. But I think this is going to get much bigger than just Medicare patients. It's going to, as the transparency creates, it'll get across the whole healthcare system of the United States. In Britain, Jeremy Hunt, who's now the Chancellor of the Exchequer, but he's done an awful lot for patient safety in the national healthcare system there, made some big differences. And he just published this book eliminating unnecessary deaths in a post-pandemic national health system, and I recommend it to you all. We've just heard from the World Health Organization, from Neelam, and Dr. Tedros has really made patient safety a global awareness issue for the last 3 years, and that too is really empowering all of us to get engaged and raise the global awareness. And actually, when I was in the Gulf states, I think at this meeting a couple of years ago, giving a talk on patient safety, one of the nurses in the audience got up at the end and said, you know, we all can make a difference. We all need to become patient safety soldiers. And I really applaud her for that statement. I think it takes everybody. We've got to get everybody in the system empowered, really looking to prevent errors so that we can really make our healthcare system safe. And so we need a patient safety army, more than just one of us. We need an army. And that includes, as I started out with, patients and advocates. The patients do need an advocate, but the patients also need to know what questions should they be asking. They need to come in with a list of questions or symptoms that they need to be giving that are important. We need healthcare professionals to be part of this army, of course. Med tech companies to create little gizmos that now will prevent us from getting pressure ulcers, prevent patients from falling, prevent patients being found dead in bed in our hospitals. Our hospitals should be the safest place in the world, and yet they're not. And, you know, driving your car now, you can't back into a brick wall. You can't get out of lane with the car shutters or pulled you back in lane. We need these small devices that will help keep our patients safer and not tie them to a bed, not tie them to a monitor in the room, but let them ambulate. And that technology is out there now. We need to let these companies know what it is we want measured and how we want it presented to us. We need the politicians, as I've mentioned, and we need a National Patient Safety Board to look at the major problems that we have in healthcare in each country. And every country may be a little bit different, and see what we can do to make it transparent, broadcast it, but look for solutions as well. And I have one more little video here.
It took me 10 years of almost weekly physical therapy to get back to a new normal life.
I have a memory of my husband walking down the hall of the hospital, and I was sitting on the floor, and I looked up and I said, Leah died.
It took me 10 years of almost weekly physical therapy to get back to a new normal life.
I have a memory of my husband walking down the hall of the hospital, and I was sitting on the floor, and I looked up and I said, Leah died.
A 27-year-old young man with a normal, healthy heart and lungs should not die of cardiopulmonary arrest in a trauma center intensive care unit.
You know, we've learned a lot in healthcare, and we're better than we were 10 years ago.
We can't set the target at some harm or a little harm. Our target has to be no preventable harm.
We can't rely on someone on our left side or right side to solve a problem that is ubiquitous and as challenging as humans making errors. Whether you're a doctor or a nurse, CEO of a hospital, CEO of a medtech company, an engineer, government, or someone who cares because you've lost someone, we have to all come together and put an end to it.
In theory, we could all be celebrating 10 years of essential work, celebrating all we have achieved together, all the harm that has been prevented, all the lives that have been spared, and all the safety protocols now in place. But when the goal is zero harm, celebrations can wait. Especially at this moment in time, after a worldwide pandemic has pushed the number of preventable deaths and injuries even higher and has pushed healthcare workers to the limit. Yet dampening celebrations is one thing, dampening our resolve is another. Of course it's not a perfect world. A perfect world would not need us. Our work is more vital than ever. We can't do it alone. We never could. It takes all of us, patients, caregivers, and families working together, reaching across borders and disciplines, drawing from each other for the ideas, the innovations, and the energy needed to reach zero preventable deaths by 2030, leaning on each other the way we always have.
So thank you very much, Dr. Ramsey, for an amazing lecture. Before we go into the Q&A, at some point we had almost more than 2,400 attendees, and I can tell you that you listened to 3 amazing speakers talking about very, very practical, solutions for patient safety with huge experience. My ask from every one of you, the 2,400 of you, is if you could just tell 10 other colleagues of yours, when you go back to work, about 1 or 2, lessons learned from today. So, and ask them also to spread the message. So from the 2,400, we can end up with 24,000 people that heard this message. And I think that can actually push the agenda forward. I'm going to say this in Arabic. الرسول صلى الله عليه وسلم كان يقول بلغوا عني ولو آية فرب مبلغ أوعى من سامع. Basically, part of what you heard actually could really get traction as we're moving forward. So we have time for Q&A, and Dr. Ramsey, again, thank you very much for the great presentation. What can you speak a little bit about the?
Sorry, I can't hear you.
Can you hear me? Maybe your audio is. Can you guys just check Dr. Ramsey?
Hello, I can hear you. I can't hear Dr. Abdullah. Leila.
So he will be with us in a minute. I think it's almost 1 o'clock or beyond where Dr. Ramsey is. So again, we really appreciate his time with us. So while we're waiting for him, one of the messages that he talked about is the transparency. I think he really highlighted transparency. He talked about why it is important to have him to have the not just the C-suite at the executive level be involved, but also to have safety be a priority at the board. the question that I ask every one of you is safety a priority at the board in your organization that you work at? And how is reporting happening? We're hoping that we can bring Dr. Ramsey back.
I think I'm back, maybe.
Can you hear me now?
I can, yes.
Perfect. So I was going to ask you about the lead indicators. So the majority of KPIs in patient safety are in a way or another, you can look at them as an assessment of a failure, of harm. So how can we, if we really want to try to prevent harm, also try to move the needle towards upstream in the process, looking at some lead KPIs, try to leverage, you mentioned technology, how we can leverage also machine learning and AI in picking up the upstream in the process, the potential of harm before we end up with those hospital-acquired infections or pressure injuries or others.
I think there's more and more AI technology coming out that will help with this. I know, for instance, just again in my field, we can tell when a blood pressure is going to drop about 15 minutes before it does. There's some technology now that will show you that on a patient. But I think the key, we've got to get transparency on the data, and somebody's got it. The payers have it. The government has it in the United States, but the payers have it too. And somebody's got that data, and we need to publicize it, because once we publicize it, we're all competitive to a degree. And if your results are better than my results, I'm going to start doing something different. I'm not going to conceal it anymore, because I won't be able to. It will be out there. And so I'm going to improve. And I think it drives all of us that if we start to see the data, I mean, in my own hospital 10 years ago, we did not know what the infection rates were. We did not know what the central line infections rates were. We did not know what the preventable deaths were. We just know occasionally one or two we'd hear about, but we knew no details. That's totally wrong. We have to publicize it. We have to get over the attorneys. We have to sit down with the families and talk to them. We've got to let them know what's happening, because we will get better. Once we start to really humanize these errors and not conceal them, we will get better. And we need a big push to do that. And that big push is the data is out there. Somebody's paying for the complications. Somebody's seeing that that patient did not get out of hospital when they should have done. That data is now electronic, and we can screen the electronic data. There are computer programs out there now that you can buy that will download and show you where major events are happening that up to now would not be reported. But we've just got to get them reported. We've got to get the payers to report it if the government doesn't want to get into it and report it. And they may find that difficult because so many lobbyists will affect the government, et cetera, that have to get it voted in. But the payers can do it. And they will save themselves a lot of money if they can show us the preventable errors that are occurring, the number that are occurring, where they're occurring, in which hospitals are they occurring in. I know it's blunt, but honestly, that will change practice very, very fast.
And, part of our transformation, the healthcare transformation in Saudi is also breaking down the Ministry of Health into a regulator, a public payer like CMS, and also a healthcare provider, which is a health holding company. So I hope that some of the payers' employees are with us today, because I agree with you about this aspect. And I think you answered in your answers, there was a question about measurement and benchmarking, which you alluded to. So there was also another question about incorporating, what are the efforts taken to incorporate safety in medical and nursing curricula?
We've just awarded a scholarship for $100,000 to Keck Medical Center to put that curriculum in place there, and then see if we can't get it to spread further across the country. There are several organizations starting to do that. Geisinger, I know, put one in a couple of years ago in the United States, but there's not enough. There's absolutely not enough. We need to have patient safety in nursing schools, medical schools. We need to have it basically in high school so that children growing up, they're becoming adults, they're aware of patient safety. It's something we can make a big difference in. Right now, we're just scratching the surface. We've got to do something much more, and education of the general public is number one.
Amen to that. The last question, do you think zero harm is applicable in all patient safety events, pressure injury, for example?
No, but I think we can do much better. We can do a lot better. And who knows, if you don't aim for zero, you'll never get there. So I think we've got to see what our limits are. But there's certainly many things we can do to prevent pressure ulcers. And I think we're starting to see that being attacked in many healthcare systems. But first of all, let's get the number, let's get the data, and let's see who's doing it right and who's not doing too much to really prevent them.
Perfect. Well, with that note, I would like to thank you, Dr. Ramsey, for an amazing presentation and for staying way up late to be with us. And you've been with us in person in the past, in the previous conferences. Also, I'd like to extend my gratitude and thanks to Dr. Neelam from the WHO and to Dr. Paul Bowie, and we wish him a speed recovery. And my thanks to the organizing committee and the Saudi Patient Safety Center, and my thanks to you, the audience. We reached 2,500 people attending online, so that's a big number, and that's a very good sign that people are very interested and hopefully committed to pushing the agenda of safety forward. So. Again, I thank you all, and Dr. Ramsey can get some sleep, and hopefully we'll meet in person in the not so distant future.
I hope so. Thank you so much, Dr. Abdullah. Thank you.
Okay. Take care.
Bye-bye.